بسم الله الرحمن الرحيم. في البداية بحب أشكر أستاذي الدكتور أحمد عبد الجليل، دكتور قسم القلب بمستشفى إينا العام، دكتور أحمد عبد الباقي، دكتور أحمد زقيم، دكتور مخلص، وكل أعضاء الاسم بمستشفى إينا العام. ألف مبروك مؤتمر اسم إينا العام. وأنا دكتور محمد أبو-القاسم علي، مدرس أمراض قلب أسيوط، بس أنا بفخر برضو إن أنا ابن من أبناء محافظة إينا مدينة إينا يعني. فإن شاء الله تبقى المحاضرة بتاعتي سيمبل، إن شاء الله تبقى انترستنج. هي تكملة لمحاضرة الدكتور خالد المغربي عن coronary syndrome. My title is Ischemic chest pain with normal coronary angiography. يمكن الدكتور محمد كان علق على النقطة دي في آخر محاضرة الدكتور خالد، بس أنا هنتكلم عنها في صورة case presentation. Our patient is 58-year-old woman, complains of chest pain. She is known to be hypertensive. Chest pain characters: retrosternal, compressing, increased by exertion, relieved by rest, and progressive in last 2 weeks. On examination, pulse 70 beats per minute. Blood pressure 130/80 millimeter mercury. Chest and heart clinically free. Her ECG was sinus rhythm within normal, no ST or T wave changes. Echo, no segmental wall motion abnormality. Ejection fraction 62%. Lab investigation: hemoglobin 12, creatinine within normal, LDL 110, and hemoglobin A1C 5.9. And she underwent exercise ECG, which was positive at that time. After exercise ECG, coronary angiography was ordered, and it was this. This is RAO cranial view of the LAD. We see LAD with septals and diagonals without atherosclerosis, some atherosclerosis, but without significant obstructive lesion. This is RAO caudal view showing left main, LCX, and proximal LAD. Just some atherosclerosis, but without obstructive lesions. Also, this is RAO caudal view. This is the RCA, showing dominant RCA with BL and BADA branches without significant obstructive lesions. So after this coronary angiography, what shall I do? Female, 58, hypertensive and complaining of typical angina pain, retrosternal, compressing, increased by exertion, relieved by rest, and positive stress ECG, and normal coronary angiography without obstructive lesions. Should I stop everything, or congratulations, you have nothing, or what to do? Control risk. Yes. She is hypertensive. LDL hyperdyslipidemia. بالظبط. So after this, we have this slide summarizing our patient. This lady has angina or angina equivalent symptoms, and we have non-invasive functional tests, but in this case we don't have functional tests. We have just exercise ECG. But if it was evidence of myocardial ischemia, so we are suspicious of ischemic heart disease. She underwent invasive coronary angiography, and it was without significant coronary lesions. So we have a case of INOCA. What is INOCA? I will talk about definition, clinical importance, endotypes, how to diagnose, and how to treat this INOCA. INOCA is a term. Okay. Yeah. Okay. So INOCA is ischemia with non-obstructive coronary lesions, less than 50% stenosis in the epicardial coronary arteries, typical angina, and positive evidence of myocardial ischemia, either invasive or non-invasive. So what is the clinical importance? So in these cases, they are complaining of recurrent chest pain. They have impaired quality of life. There is recurrent hospital admission with increasing chest pain, typical angina, unstable angina, and every 2 years undergoing coronary angiography. It is normal. So also in multiple studies and meta-analysis, these patients compared to normal patients, they were found to have an elevated risk of MACE, major adverse cardiovascular events, like especially heart failure with preserved ejection fraction. So what is the types of INOCA? What causes INOCA? There is multiple subtypes of INOCA. INOCA is a term, but what is the pathology? What is the pathophysiology? 51% of cases have microvascular angina, and 17% of patients have vasospastic angina. 21% have mixed microvascular and vasospastic angina, and these patients were found 11% to be non-cardiac chest pain. So how to differentiate these subtypes? This diagram represents the coronary circulation. We have, sorry, is it marker? Marker? So we have the macro circulation and micro circulation. The epicardial coronary we see in the coronary angiography is the macro circulation. But what about the micro circulation? The micro circulation is responsible for regulation of blood flow. So these micro circulation have to vasodilate in response to stress to make blood flow more and increase oxygen demand of the myocardium. So when we have pathology in the microcirculation, like microvascular angina, in patients with elevated risk factors like hypertension, diabetes, dyslipidemia, patients with oxidative stress, endothelial dysfunction, we have impaired vasodilator capacity of the microcirculation. So this is the pathophysiology of microvascular angina. And in the macrocirculation, in the epicardial coronary, sometimes we have vasospasm. So this is the pathophysiology in vasospastic angina. So we have microcirculation and macrocirculation. The guidelines, ECC guidelines for chronic coronary syndrome recommend guide wire-based CFR coronary flow reserve should be considered class 2A in patients with persistent symptoms about coronary arteries are angiographically normal or have moderate stenosis with preserved IFR or FFR. And intracoronary acetylcholine test for vasospastic angina and microvascular spasm. With class 2B recommendation. Also class 2B recommendation transthoracic Doppler of the LAD, CMR, or PET scan may be considered class 2B indication. For non-invasive assessment of CFR. CFR is the coronary flow reserve. We have to investigate it either non-invasively with CMR, PET scan, or transthoracic Doppler, echo of the LAD, or invasively using guide wire-based CFR and intracoronary acetylcholine for microvascular spasm and vasospastic angina. Also, class 1 recommendation, ECG, invasive angiography or CT in patients with persistent chest pain, and ambulatory SCT elevation monitoring in patients in suspected, should be considered class 2A in patients to identify SCT deviation in absence of increased heart rate. This ambulatory SCT holter in patients with vasospastic angina, because sometimes we have patients with baseline normal ECG and have typical chest pain. If we do Holter, we can see ST elevation in Holter, which indicate vasospastic angina. And the intracoronary provocation test with 2A recommendation should be considered. So what is the invasive coronary function test? FFR, coronary flow reserve, CFR, and index of microcirculatory resistance, IMR, and the provocative test for vasospasm, acetylcholine. To differentiate subtypes of INOCA, so we have microvascular angina, FFR is normal, CFR is impaired less than 2, index of myocardial resistance more than 25, so it is positive, acetylcholine negative, acetylcholine test for vasospasm is negative, and the patient has angina and ischemic ECG changes. Vasospastic angina, FFR also positive, negative, more than 0.8, CFR is negative, more than 2, IMR is less than 25, so it's negative, but acetylcholine test, provocative test for vasospasm is positive, with angina and ischemic ECG changes. Both microvascular and vasospastic angina, FFR is negative, CFR negative, IMR negative, acetylcholine test may be negative or positive. So when it is positive, when we have microvascular spasm and not epicardial spasm, and angina and ischemic ECG changes. Sometimes we have non-cardiac chest pain. All investigations are negative, FFR, CFR, IMR, acetylcholine, and no angina, no ischemic chest pain. So how to manage these cases? First of all, lifestyle factors, modification, nutrition, exercise, weight reduction, smoking cessation, coping with stress. Second, risk factor management, control hypertension, control dyslipidemia, control diabetes. And anti-anginal medication. For microvascular angina, we can prescribe beta blocker, calcium channel blocker, nicorandil, ranolazine, ivabradine, or trimetazidine. And for vasospastic angina, we can prescribe calcium channel blocker, long-acting nitrates, and nicorandil. And for both, we should consider statin and ARBs or ACE or ARBs. So back to the title of my topic. It is ischemic chest pain with normal coronary angiography. Is it normal? Structural versus functional. We should think about the function of the coronary. Is it microvascular or vasospastic angina? And thank you.